this week on the BackTable podcast.
As you know, that even in the mammogram, that about 68% of the time, the mass is not really typically present. It's only sometimes that it's architectural distortion, which is kind of like a changes of like crinkle-like changes in the stroma, in addition to thickening of the skin. So these are kind of changes that we see even in the clinically. So it's very confusing type of picture. And then one thing to note is that these type of changes from like, hey, something's not right with one breast to the point of diagnosis that, like by the time that a lot of times patients will know now they can no longer fit the bra, even on the t-shirt, their one breast looks heavier and, more like prominent. That changes usually happens within 3 months period of time. So these changes are also very rapid. So these are the typical findings of the IBC.
I'm Lindsay Peterson, breast medical oncologist at Washington University School of Medicine in St. Louis, Missouri. Here today with Dr. Bora Lim of MD Anderson to talk about inflammatory breast cancer. So Dr. Lim, welcome. Thanks for being here with us today.
Thank you, Dr. Peterson. It's an honor and privilege to have a chat with you, for something that's small but very important topic, at least for us and patients. So thank you.
Well, I'm so happy that we get the chance to chat about this. It's such an important topic. Tell us a little bit about yourself and sort of what led you to have an interest in inflammatory breast cancer.
Yeah, so I am a breast medical oncologist like, yourself, that I see patients maybe in about a day or day and a half, per week in the clinic. My patients are usually made up of, young breast cancer that is kind of hard to treat. And so while more than 3 to 5% of the patients are so cured from the breast cancer diagnosis, my clinic focuses on patients who may not be able to be cured or have a very difficult to cure type of breast cancer. And so that my aspirations to help these patients who are suffering from something that is supposed to be easy but not so easy in combination with the translational science brought me to, some of the aggressive cancers like inflammatory breast cancer. So when I joined as a faculty at MD Anderson, like more than 10 years ago now, that I automatically kind of attracted to this IBC group. So we have a dedicated scientist and clinicians who are focusing on IBC. So I became a part of the group that which gave me even more motivations to bring new trials and new therapies for this group.
That's great. It's obviously, we see this a lot, but it's a rare presentation, right, overall compared to what we're used to. And so it's really nice to have dedicated centers and people dedicated to this particular disease, because I think that's really important when a lot of general oncologists across the country are not seeing this on a regular basis.
Yeah.
Tell us a little bit. It's obviously a bit of a unique presentation. I think most people know that it's a clinical diagnosis, but there's a lot of different ways this can present. Tell us maybe a little bit about the typical presentation and then maybe any situations where it doesn't present in that typical manner that most people think about, so they can make sure that they're thinking of it in those less typical situations.
Yeah, so it's a shame in some way that we are still diagnosing IBC or inflammatory breast cancer. We call it as an IBC in short, in relying in more of a clinical presentations. But I think it's important for us to know that what it might look like, what it might sound like. And so when I talk to my fellows or, trainees, that I tell them, hey, in the whole room, you might be the only one who has ever seen or heard about the IBC, and that you might alert everybody to think about, because, if you don't have a suspicion, then you wouldn't be able to diagnose properly. So the usual kind of textbook presentation goes like this. It doesn't matter how old, we see either young or very old, even, 70-something or even 80-year-old patients who one day notice that there's some changes in one of the breast, usually, that, some patients might think, I played the tennis, maybe too much, that I had a very sweaty bra, it feels like my right breast feels heavier than the left, or have a little streak of redness or changes in the color of your skin that you did not notice before. You're like, maybe it's just oversweating. Maybe I got a little bit of bug bite, who knows? But then that lesion or the changes doesn't really go away, but rather it gets worse to the point a lot of times that these patients will end up calling their primary physician or the gynecologist or dermatologist, depends on which one you have the most access to. And then usually ended up getting the diagnosis of something we call mastitis. So they will say, oh, you have this blocked milk duct, or, you have the infection that, we can treat you. So ended up getting antibiotics, and, sometimes even multiple rounds of antibiotics keep changing to the point finally somebody has to, turn the light and say, maybe it's not an infection, maybe it's getting worse, maybe it's something else. And then even in some cases, the patient has to be their own advocate demanding, can it be something else? Can we get the breast imaging and get the proper diagnosis? To the point that finally, if it's young patients, even had to get the ultrasound in addition to the mammogram, get the biopsy, and then have to have a confirmation of invasive carcinoma that is in one of those lesions. As you know, that even in the mammogram, that about 68% of the time, the mass is not really typically present. It's only sometimes that it's architectural distortion, which is kind of like a changes of like crinkle-like changes in the stroma, in addition to thickening of the skin. So these are kind of changes that we see even in the clinically. So it's very confusing type of picture. And then one thing to note is that these type of changes from like, something's not right with one breast to the point of diagnosis that, like by the time that a lot of times patients will know now they can no longer fit the bra, even on the t-shirt, their one breast looks heavier and, more like prominent. That changes usually happens within 3 months period of time. So these changes are also very rapid. So these are the typical findings of the IBC.
I think one thing you said there is so important, which is these patients do typically present to other physicians, right? They're internists, they're dermatologists. So as important as this conversation is for oncologists, it's also really important for those other specialists, primary care providers, to know what to look out for to try to reduce that delay in diagnosis that you mentioned we often see.
Absolutely. So actually, there were a few cases that who came to our clinic that, who came to our, the referrals of multi-team inflammatory breast cancer group relatively quickly. And we're like, how did you, who sent you here? And then sometimes they will say, it was the nurse practitioner who attended this kind of like awareness, lecture. And then they were like, could it be, something called IBC? And then the whole medical team, going to the Google, and ChatGPT. And then they're like, that it actually could look like this. And so, even though it actually exists in our oncology board, it is actually even more important to kind of have other professionals to be aware of this disease.
Yeah, absolutely. And it sounds like, through lectures and other things, we're able to get the word out there. But I just think that's so important to mention. Okay, so you talked a little bit about the typical presentation. I think some of those things, hopefully people are well aware of: the skin thickening, the rapid presentation, the skin involvement, whether it's the erythema or sort of that classic poda-orange. Are there atypical presentations that you think people need to be on the lookout for?
Yeah, so the thing is, there are a few barriers that, we are all human beings and no humans are equal. Everybody has their own unique biological makeups and different ethnicities and backgrounds and so on and so forth. So in some way, there's some atypical findings that it makes the diagnosis challenging. The first thing I would mention is if you have a dark skin. So for example, my patients who are, either Hispanic with the dark skins or African-American descent, sometimes what happens is they're like, I have this weird heavy breast. It doesn't really feel right. They go and see the physicians and, talk about possibility of breast cancer, diagnosis. And they're like, yeah, but you don't really have a redness. But, for a lot of my dark skin patients, it can never be red. It can actually look more like either gray or purple. And so we, in our new kind of guidelines, 수전지 Komen scoring system, we try to remove that erythema. And instead, we are trying to replace that with the color changes that is not usual for you. So that way, we can also detect some of the atypical cases. The other rare but existing cases is that a lot of times, if you're diagnosed with the primary IBC, we think that this breast changes has to become as a primary, from the breast that had never been touched by the cancer before. However, we also have seen some cases where patients who had a cancer, was stage 1 or 2, long time ago. And then now a few years down the line, now they have this very typical presentation of IBC. And, in these cases, we will think about, hey, this might be a residual cancer from the previous cancer, maybe left untreated, now becoming locally advanced, but their molecular subtype is quite different. Their Ki67 is different. So it actually does look like a new primary presentations. And so we have seen such a cases. And sometimes that happens immediately after, having the late birth, pregnancies and things like that. So we think that there's certainly a very textbook primary IBCs, but there's also these cases that brings up the changes in the breast that makes your cancer like primary IBC.
So looking out for recurrence of cancers that are presenting inflammatory as opposed to automatically assuming it's a new primary.
Yeah. And so in some way, it's kind of like fine decisions, among different experts. We have to look at the imaging, pathology, have to look at the clinical presentations. But some of these kind of questionable IBC might be better be treated as an IBC and be more aggressive to have the best survival outcome. I think the things to lose is higher than, like trying to have the debate and clean diagnosis. So I think atypical IBC should be also considered pretty seriously.
Yeah. That's great information, I think, for everyone to know. So you talked about survival. You talked in the beginning about how you wanted to help this group that, doesn't traditionally have the highest rates of survival that we're used to seeing with breast cancer. How does that play into when you're working this cancer up? So we know in the majority of cases, we're not getting staging scans for our early breast cancers that are presenting. In this case, are you getting them routinely on everyone? Do you simply have a lower threshold? How do you approach that diagnostic workup? How is that different than your typical breast cancer cases?
Yeah, so that's a great point. That one thing that makes a little bit easier on the IBC in the arguing about the staging cases is that sometimes it's an argument. So if somebody has a skin involvement, whether clinically or skin punch confirmed, skin involvement, in the past, actually, people were mandating the skin punch to prove that it's an inflammatory breast cancer. The tricky thing is, if you're not somebody who's seeing this IBC in multiple fronts, you may not be able to select the right area. So even if your skin punch biopsy is negative, it does not guarantee that it's not truly IBC because it could be completely selection. But once you make up your mind that you do have a skin changes, so then the decision becomes if it's T4B, which is the residual, like a long-term remaining locally advanced, versus T4D, which we are seeing that tumor emboli going and attacking the lymphatic duct, creating this Botorange-like changes and the swelling, and therefore it's a truly existence of the tumor emboli causing the skin changes. Once you have the T4D, automatically your staging becomes stage 3, which is then, mandating the systemic staging. The one thing that we try to do routinely are two. Number one, we try to do more of a PET-CT scan. And in the breast routine staging, of course, PET-CT scan is not necessarily the primary recommended staging. However, as you know, the PET is really great at detecting the myeloid cell activity. So if the tumor cells has a lot of interaction with the myeloid cell that creates a lot of like glucose consumptions and other activities, that is a perfect disease to light up in the PET-CT scan, like lymphomas and others. So if you use the PET-CT scan, you actually have a way higher, especially in the lymph node diagnosis. IBC also presents a lot of distant lymph node that is in addition to the primary. So the detection rate goes up pretty high. And so if the insurance permits, we try to fight, and get a PET scan for all these patients as much as we can. And also the importance of that is many of these patients would have a high neck node involvement even at the diagnosis. So that could actually cover very nicely. And then that could give us the planning for later, even local therapy for surgery and radiation. The other thing is, it's kind of like debatable still, but at least in our current institution, we try to get MRI of the brain, for all patients.
That was going to be my next question, is if you're doing that.
The incidence is just too high to miss. And the composition of the molecular subtype of IBC is 1/3 TNBC, 1/3 HER2, and 1/3 ER positive. And even in the ER positive IBC, there's high propensity of going to the CNS space. So we really try to advocate for the brain MRI, even at the baseline.
Yeah. You said three things that I think are really important to reiterate. So one, the skin punch biopsy is not required. I think most people know that, but we do see that sometimes when someone says, but the skin punch was negative, right? The other thing is, you're right, people are used to ordering CT, chest, abdomen, pelvis, and a bone scan. That's sort of the typical workup. And so important to remember for these patients, as you mentioned, as long as we can get it through insurance, getting the PET scan. And I certainly don't think people with their routine patients are used to the screening brain MRIs like we do in lung cancer and other diseases. So I think those are all, very important points to remember, when people are seeing or treating IBC when they're not used to treating it on a regular basis. So you mentioned sort of the breakdown in subtype, which is equal, about a third, a third, a third. Any aspects of the treatment of those that you think are important to mention that are different than how we would treat a stage 2 HER2 positive, a stage 2 triple negative?
Yeah, so that's another important point. So, in our institution, so we actually are about to celebrate our 20th anniversary of state-funded institution that is dedicated for this disease.
Oh, that's
which is
amazing.
Quite exciting.
Congratulations. Yeah, that's quite a feat.
Thank you. I know. And that long-term, special care for this rare cancer brought up, actually, we just celebrated our 1,000 patients registry that it was registered for our MD Anderson IBC registry. So once you have this many accumulated data, there are a few things that you can really learn even by looking at the pattern. Is that compared to initial part of our journey, like from 2007 to 2014 or 2015, kind of all subtypes kind of suffered. But then if you look at our more modern data for the last 5 years to 10 years, thanks to a lot of this great, medication that is targeting HER2 positive IBC patients, regardless of whether they're stage 3 or 4, do really well. So those patients, just like any other HER2 positive patients, they have been doing fantastically. Still, the amount of the surgeries and radiation that we have to do, including the axillary node dissection, which leads to one of the lethal, morbidity of the lymphedema. Now we are actually at the point for HER2 positive IBC patient, we are thinking about how we can potentially down-tailor some of these aggressive surgical techniques. And so we are working closely with our plastic surgery and our breast surgery group, trying to come up with a plan. Maybe not every HER2 positive IBC patient, once they have a fantastic response, need to get that aggressive treatment. And yet, even in those HER2 positive patients, if you compare regular, standard like TCPH response, still compared to like 65 or 70% PCR rate, ours is around like 40-45%. So still there's a gap of the PCR. If you look at the ER positive or triple negative, it's even worse. And so even our best regimen, Keynote 522 in triple negative, like that's our current standard. The patients still achieve about 39% PCR rate compared to other TNBC patients. So that's, not the best. ER positive is obviously way worse. We just suffer as much as, any other ER positive aggressive patients, but even worse. And if you compare all of the survival rate, if you achieve the PCR, your outcome is better. But even patients who are able to achieve the PCR, still many of them end up getting a brain recurrence and PCR. So we are also trying to highlight some of the improvement of how we actually diagnose this patient by implementing ctDNA, MRIs, and some of the other imagings. And, one thing I had to confess is while we had many rounds of the clinical trial that we tried to design against IBC that is specifically designed for our patients, that thing has been a home run. We still don't understand a lot about this disease. And so in 2026, we have a few ammunition that we have it ready. We think that maybe there might be a home run for our IBC patients. So more to come.
Yeah. Now, a couple of questions. So these 2026 maybe to come, are these the agents that we're newly using across the board in breast cancer, or are you looking at specific agents that are being used really particularly for inflammatory breast cancer?
Yeah, that's a great question. And I think that also brings up the kind of my one other side of my life, which is the drug developer or translational researcher. And so, when I was more green, I used to have this dream like, oh, we're going to find this like very unique treatment that is nothing else is going to be used, but it's going to like come and eradicate the whole cancer. But I think one thing that we have to remember is the patients are dying like today. We lose our patients every single day. So in current status, I think the best strategy is to combine the best kind that it has a still access that's available for us, as a more like a breast cancer community, and then grab them and make the best combination. And so a couple of the trials we're trying to do is actually utilizing, the one trial that we're trying to do in induction therapy is actually utilizing both more breast relevant agents together. But then actually we do have another trial that we were designing. That one actually we were trying to bring some like bladder regimen. So we'll see how that goes.
Okay. I saw eribulin in one of your publications. Is that one of the agents that you're trying to bring in?
So the eribulin combination, so there was actually the triple combination regimen. It was the cobimetinib, which is the MEK inhibitor, and then eribulin as kind of cytotoxic therapy backbone. We are using it only for 4 cycles as an induction, and then the partner of the anti-PD-L1 atezolizumab. So patient would receive the first 4 weeks of only cobi and atezo, and then have the eribulin added for 4 cycles, and then eribulin drops, and then the maintenance with the biological agent. We did have quite a promising response rate. Of course, it's a phase 1 study, so there's still a lot to learn. And unfortunately, the cobimetinib program shut down, so all the MEK inhibitor kind of like graduated from the solid tumor. So there was a shame. But honestly, even though the number of the patient was very small, I think we're actually going through the revision right now in the publication. 2 actually metastatic triple negative IBC patients are still alive. One of them is not on a treatment. One of them is still on atezolizumab and cobimetinib treatments like beyond like 7 years. And so there's some patients I think that we can certainly make a difference with the novel agent. The new agent we're trying to bring in is one of the fancy like bispecific.
Okay.
Yeah, they were trying to tap on immune microenvironment and also resistant mechanism, which is angiogenesis. And in addition to the cytotoxic therapy. So if that materializes more, you'll be the first one to know.
Well, I appreciate that. You mentioned, a couple other things in terms of surveillance. So again, talking about how management of these patients is not the same as our other, stage 2 and stage 3 non-IBC patients. How are you doing screening for them? Typically, we're not doing, surveillance scans, ctDNA. Some people are using it. Some people are waiting for more of a clinical action to be tied to it to use it routinely. But how are you surveying these patients, months and years down the road after they've completed their primary therapy?
Yeah, so it's a little bit of mixed group because, as you know, that the ctDNA for breast group is relatively newer compared to some of the other disease types like GI or colorectal group. So in our group, what we have done is that we have a research collaboration with one of the ctDNA companies. And, we have multiple collaborations, but mainly on the focus of IBC, we have one company we are aligning ourselves. What we do is we actually commercially send our testing of the ctDNA at the beginning of the treatment. And then we kind of monitor them throughout the neoadjuvant induction therapy and continue to monitor them in the adjuvant. And so far, what we have observed is that both stage 4 and then de novo stage 4 as well as the stage 3, the ctDNA actually tracks really, really well. And, I know there's some argument as to, hey, how much of the sensitivity that we need, do we need a super sensitive testing, is the current testing enough? Surprisingly, almost every single IBC patient, even in the stage 3, they have a very high level of ctDNA, even at baseline. So that kind of gives you more affirmation of the biology that even though your IBC patient in front of you, based on the standard staging is stage 3, they're really little at the verge of stage 3 to stage 4. So it's kind of like instead of trying to monitor their MRD and trying to prevent the recurrence, rather it's more like you try to halt before they become stage 4. So you have to almost like eradicate them. And that's where all the ctDNAs and the surgery, aggressive local therapy actually goes in. But I'm not saying the ctDNA is perfect, but it actually certainly gives you additional arm of information. In addition to that, we are also trying to bring in things like circulating immune markers. And so we actually do have some separation of the patients where some of the patients are able to maintain intact T-cell program compared to some of the other patients, their T cell exhausted, like even at the beginning of the adjuvant therapy, which will be very high risk of the recurrence. And so in near future, we hope to have a multi-omic monitoring system where you can have like, hey, you're very high risk of recurrence. Let's have you more like close monitoring versus the patient who has a good profile, give them more reassurance. And so I think the whole oncology might head to that way.
Yeah, definitely. Have you guys designed any trials or thinking about, so for those patients who don't clear, who remain, ctDNA positive after what the best therapy that we can give them, are you doing more for those patients to try to get them to a negative result?
Yeah, I mean, so that's I think a few two-folded questions. Like number one, I think it's ideal if we could achieve the molecular clearance even before we go for local therapy. So I think in IBC field, which I don't know if you're going to touch on later on, is that there's a lot of argument about, how much local therapy is really needed. Because, stage 4 especially, the stage 4 surgery has never been really proving to be beneficial for survival. IBC is one of those very rare cases where we do have a lot of retrospective data where if you can do both radiation and the aggressive modified radical mastectomy, your survival improves by 50%, which is non-significant. And of course, we accept the fact that it's all selection bias, but maybe that selection bias is important. So we are maybe selecting those patients who can really make them like an NED early on. And I think one of the factors that we are learning is that the surgery or radiation is not only having this physical impact, but actually changes your vascular system and the immune system, which are the two important factors that makes your IBC resistant and also persistent. And so we are trying to, have a exam of the tissue that if you remove them, like all the lymphatic vessel, all the lymph nodes and all the blood vessels and removing all this supporting vessel, maybe actually we are changing more geographic support of the VEGF system in general altogether, as well as the interferon system in your body. So it's not just a local impact, but you're changing the whole global host response. And maybe that's where the whole benefit actually comes from. So knowing that, what we are trying to do is, there's a lot of MRD study that actually I know you, Lindsay, are also part of, and we're trying to move through a couple, really solid ideas of the MRD clearance, like treating them before they become imaging recurrence. So I'm actually part of such an effort for overall breast cancer patients. But for aggressive patients like an IBC, we're actually trying to give them all the intensified therapy regardless of the MRD at the time of the surgery or local therapy. What we think that might be more important is the baseline and then the clearance immediately after starting of the systemic therapy. So in some way, if somebody had a level 5 high grade of ctDNA, I give them neoadjuvant therapy. And then even though they're like stage 3C, they can clear the ctDNA to the 0 immediately. Those patients do really, really well. And so that's how we can use that more of a stratification factor, understanding ctDNA dynamics.
Yeah. So it sounds similar to a lot of what we've seen, with the ctDNA's studies so far, which is definitely prognostic, trying to get to the point where we can actually change the outcome, based on what the results are. You touched a little bit on CNS recurrence, even the patients with path CRs having CNS recurrences. Two things I think important to talk about is a path CR as predictive for these patients as others. We know they don't achieve a path CR as much, but when they do, can you put as much confidence in it with their recurrence rates? Are they actually not getting that same increase in disease-free survival that we're seeing in other cases? And two, outside of the CNS, is there another particular type of relapse pattern to be looking out for?
So both are very important questions. So one thing we note is that there's a clear separation of their long-term outcome between patients who are able to achieve the PCR versus non-PCR. So there's a clear difference in their outcome. However, the kind of sort of like sad part is that even the patient who achieved the PCR, it's not a guarantee that your cancer is not going to return. And therefore, we need to have a better diagnostic and better therapeutic intervention in those patients. And so, for example, if you compare like CTC, ctDNA, PCR, all of them kind of individually, they kind of perform pretty equally. So like a CTC at the time of the surgery could actually predict as well as, PCR. And then one thing we notice is that if you combine circulating marker with the surgical outcome, we can even intensify those predictive markers. One thing to note here is though, as a group, actually, we think that current RCB, which is, calculated and created by our own group at MD Anderson, is not really perfect for IBC. If you look at how this RCB is calculated in the calculator, you basically give you more like bulk information. But as you know, IBC exists in the spots. We are like broccoli. So it's really hard to determine what is the percentage of this IBC within the whole region of the tumor emboli. What's the actual proportion of so we are actually trying to come up with our own RCB system for IBC dedicated, but that's also not that perfect. And so I think we'll have to come up with more like multi-omic prediction markers. And so we are turning a lot in the AI, so we're actually working a lot with the digital pathology and AI and trying to more streamline in those patients who's going to actually have a more risk of the PCR. And then the other thing that we note is that this PCR really does not necessarily predict how the patient is going to perform in the CNS. And so, another strategy people are talking about is, do we then have to have a midterm CNS imaging, which can then actually be integrated into AI pattern recognition? So some of us are believing, even though your brain MRI is quote unquote clinically negative, there are some patterns that we are seeing that can potentially inform you. These patients have a seeds in your MRI. They be like a ticking bomb to have a recurrence in the CNS. And so more of a precise recognition of such could also add the information. And lastly, if you have any of these risk factors that these patients are going to do poorly, then you to have a early intervention. So how to intensify those patients' treatments. So that's where some of our like novel ideas of like adding this bladder, immune agonist agent, in addition to the immunotherapy. So we are hoping that bringing all of these trials in the group. So we need multi-arm efforts and multidisciplinary collaborations.
Yeah, that's fascinating about the brain MRIs. That there might be changes on the brain MRI that's otherwise read as normal, that might predict. What a great thing to look at, with imaging colleagues to try to see if there is something, because obviously finding it early isn't the best plan, right? Preventing it is the best plan. So you mentioned a couple different novel agents, that you're looking at, or novel combinations even. Currently, for patients who have residual disease, are you treating them the same way we are adjuvantly for our residual triple negative, our residual HER2 positive? Or are you not seeing very much residual disease because you're altering their neotherapy enough that you're really pushing most people to that path CR?
That's a great question. But I think even with our best efforts, so for example, we have a novel neoadjuvant therapy that is combination of the TDXT with the anti-PD-L1 in collaboration with Dana-Farber team. So Dana-Farber is another group that has a dedicated IBC team. So the PCR rate is better than standard therapy, but not like the level that we are hoping for. So we are still left with a lot of patients who has a residual disease. We have actually completed a whole set of the ER-positive IBC patients that's adding the pembrolizumab as a immunotherapy in addition to the endocrine therapy. We're kind of touching the margin of the historical data. And so the question becomes, hey, is it better to keep adding up? Like, if you add the CDK4/6 inhibitor, then you add the immunotherapy. So I think that when it comes to these rare and aggressive tumors, a lot of people have an instinct to keep adding on. But I think we should also remember how these patients can have like more toxicity than some of the others. So even the IRAE tends to be a little bit higher than the usual population. Maybe because we are doing more aggressive radiation, maybe because we are treating them more in the urgent manner, maybe because they have a upregulated or dysregulated cytokine in their body to begin with because of the disease activity. So something to keep in mind how we're going to do this. So the one other strategy that we are trying to take is that giving them the immune fitness back. And so one of this new trial that I'm actually really trying to put together, and more than welcome to chip in your idea, is that there's this bladder medication where instead of like giving them BCG treatment, they actually add, the IL-15 agonist as a systemic therapy, trying to boost their, immune system. So for our patient, especially once we know that their immune exhaustion happens very early on during the adjuvant monitoring, can we actually give them back and IL-15 in addition to the pembro, so that we can have a more robust immune surveillance system in your body so we can actually sustain them. And then the other angle we are looking at is that having the vaccine treatments in here, there's multiple time points in our natural course of the breast cancer progression that vaccine can play a role. And I think IBC is a perfect disease in some way because their recurrence is so high. And once the recurrence happens, the outcome is dismal. So the patients would be willing to work with us and trying to do this. And so we're actually working with the two collaborators and trying to identify this hidden secret of IBC that we do the whole genome sequencing, and there's a lot of non-transcribable areas of the genome that we don't really know what their function is. But, in some way, we may not have to care, right? Like if there's a sequence that can actually be recognized by the antigen-presenting cells and they're distinct for IBC, that's good enough to create a vaccine. So we are actually trying to do that approach right now. And so I'm hoping by mid-2026, we may have such a result.
Yeah, there's definitely, across the board, we're seeing more vaccine trials, right? Both in the prevention and the treatment setting. So yeah, really fascinating about using other drugs to sort of, boost their immune response, especially when you have indication that they're not going to have the response that you want them to. So I know you mentioned Dana-Farber. There's several centers, right, that have sort of formed a consortium for inflammatory breast cancer. Are there a few you can mention just so people know geographically, options for where to send people if they do want to send them to one of these centers that really has a dedicated treatment team for IBC?
Yeah, so there's a few groups who are actually focusing on IBC, including us, MD Anderson. We are in the south, and Dana-Farber is like the northeast. And so many of our patients who are in that Boston area or have an easy access to Boston, could be good. I think actually including you and Dr. Ma, some of what you are also interested in, helping IBC. So recently we have a little bit of this formation of DART, which is aggressive breast cancer therapy research group, trying to form with the alliance with the WashU. So I don't, you should join the wagon with us.
Always open to collaborating.
Yeah, so you guys are doing a great job of catchment area, which is kind of I learned that you're encompassing larger areas in the central region. When it comes to West Coast, there's really not necessarily a center per se, but I think there's a lot of centers in Seattle where the UC group, they do have some physicians who are paying special attention to the IBC. Some of our former colleagues here have migrated into West too, so that can actually be the good hub. Ohio State has a group. There's not a lot of populations per se, but they have a very intense patient group, as well as the physicians like Dan Stovers and others who are interested in bringing the IBC as a next level care. And so that's that. Duke has a little bit of a research consortium that is budding off and, dynamically changing, and then Northwestern and the Cornell. But any one in doubt, you can always kind of work with us. We have a guidelines. We try to bring up the IBC network. And so even if you're not necessarily a center that see a lot of IBC patients, you could bring up your case and discuss. So we have I'm blanking on the name, but we actually have consortium. We can even discuss our case with the outside physicians too.
Oh, that's great. That's great.
IBC Connect. IBC Connect is the name.
IBC Connect. Okay. All right. There's so many nuances, that we've talked about, that we've brought up that aren't going to be in any guideline, right? So I think that having the ability to reach out and talk about these, more difficult cases, these advanced IBC cases, to really make sure you're doing every little last thing you can for the patient, because this is an area where every little last thing really counts, really matters a lot.
Yeah, absolutely.
Yeah. And, it still seems that most of our trials exclude our inflammatory breast cancer patients, right? And so, you mentioned immunotherapy, and we've got the SWOG trial in ER positive with immunotherapy, but most of these trials are excluding the IBC cases. So really an area where a lot of what we've learned has been retrospective, and certainly a need for prospective trials specific for, patients with inflammatory breast cancer.
Yeah. So one of the goals is, it's kind of like a part of the confession, is that, when you're working with the rare tumors like an IBC, we tend to get siloed a lot, because I think you sort of build up this defense mode and what do you mean? IBC doesn't exist. We do this so much of the research here, but we may not have done a great job of really building of the network and, really trying to work together as a group. So I think, now we have a new generation of physicians who are working in the IBC group. And I feel the change that now is the time potentially we can maybe have even first FDA approval of IBC dedicated drugs. And so hopeful. But one thing that we learned so far is that in the epithelial cells, and so tumor cells itself, IBC is not necessarily different from the other breast cancers. But what's really different is that the immune system and then microenvironment. So the systemic immune system and the local immune system. So if you can actually learn a secret from IBC, we think that it can be also widely applied for the other aggressive breast cancers. And so we hope that both way strategy, like both vertical and the horizontal, collaboration networking could really help more patients.
Yeah, that's great. It's going to take a village like everything else, right? Well, we covered a bunch, but is there anything we didn't talk about that you want to highlight, reiterate, anything else you want people to know?
So I think one thing I'm sure you might agree with me is that in general, as a breast cancer community, we are seeing more and more younger patients, in our clinic. And my 27-year-old is no longer the youngest patient in our clinic, which is pretty sad. But that brings up a unique challenges where a lot of patients are becoming like a young mom or older mom and having to deal with these breast changes and cancer diagnosis like immediately or during the, pregnancy, which sets off another kind of danger biological, challenges of this treating breast cancers and survival is worse. And so there's a sometimes fine line of, hey, is this a truly IBC? Is it more like postpartum changes? But I think the philosophy is that we need to utilize best knowledge that we have today to save this patient in the best knowledge. And so sometimes it's good to be clean cut and be more academic and discuss, hey, what's the really right diagnosis? But sometimes that having this kind of adding up resolution from multidisciplinary physicians of experts to give the best outcome for that patient. And then we can take our time to go back and study that patient's case. And so I think sometimes that we should put all of our egos down and trying to think about our patients as number one. Then maybe that way we can really bring the science to the next level too. And so my own learning, to myself.
Yeah. Yeah. Young patients are hard enough to treat, right? There's such unique circumstances. And then add a young patient with IBC on top of that. So anything else you can think of? Anything else you want people to know or remember when they're thinking about IBC?
Yeah, so one thing I would remember is the awareness for the IBC has increased a lot. So compared to 2017, 2018, when I would give a lecture and I have at least one surgeon who comes up to me and say like IBC doesn't exist. I think that doesn't really happen anymore. So one thing I would say is kind of like a buzzword. So if you have a patient with a very strange changes in the breast that does not explain by the regular infection, or you try to treat that infection and it just hasn't been resolved, think about it, that small, very small possibility of IBC. So if you do have the back of your mind, maybe you can be the one who saves that patient who needs that urgent therapy. And so, and then we always like to go with the systemic therapy first, and then followed by local therapy. We used to see more like this urgent mastectomy cases a lot in the clinic. I think we are seeing less and less in that. So I think our field is actually moving forward. But just remember, buzzword, infection like looking like breast can be cancer.
Yes. Yeah, I think that's a great message. Like we said, not beyond oncology, right? Into the primary care clinics, dermatologists, the other urgent care is anywhere that these people are presenting, right, with their first symptoms. So yeah. Well, this was so informative. This was so interesting. It's nice that there's actually so much on the horizon for inflammatory breast cancer. A lot of times with these rare diseases, we get stuck and we don't make much progress. But I think between, the various centers and the consortium and all of the collaborative research and clinical care, even as you mentioned, with the opportunity to discuss cases, I think we're really going to see some improvements in the coming years.
Yeah. And lastly, using this knowledge that we obtain from the IBC group, we're also trying to bring other difficult to treat cancer types like metaplastic, neuroendocrine. So more to come. So stay tuned. I hope that we will be able to treat all of this rare and aggressive breast cancer subtype in a very precise way. And, thank you again for inviting us to talk about this important topic.
Of course. Yeah. It was so great to see you. Great to talk with you about this. I think I actually see you in a week or two. I think you're talking on another topic at WashU. So that'll be great. We'll connect again then. But thanks again. This was a really, really great review on inflammatory breast cancer, not only on the traditional how to treat it, what to look for, but also a lot of the nuances and things to come.
Thank you.
Thank you so much for joining us on BackTable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ONC. That's _BackTable ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
Josh Spencer, and Jaden White.
Design and digital marketing led by Brian Schmitz.
social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
See you next time.